Scott Brown's Otology, Chapter 85, Ossiculoplasty. Surgical options to correct specific defects. Continuation. Malleus present, stapes absent. Austin Cartouche type B. When the stapes superstructure is absent, mechanical coupling between the stapes footplate and the tympanic membrane or malleus handle must be achieved. This type of reconstruction is inherently less stable due to the distance that must be bridged and the absence of a fixed attachment point on the stapes footplate. Several studies using multivariate analysis have identified presence of the stapes superstructure as being a key determinant of success following ossiculoplasty, with poorer hearing outcomes to be expected when it is absent. Homographed ossicle. Autologous incus is rarely available as a reconstructive option in this situation, as absence of stapes superstructure will almost invariably be accompanied by a degree of long process erosion. Homographed incus has been used extensively for this purpose, with most reports describing the long process resting on the footplate and a sculpted notch at the opposite end to accommodate the malleus handle. Results for these techniques are highly variable. Figure 85.5. When the malleus is repositioned over the stapes, the undesirable tilting force F3 is reduced. Alpha equal to 0, F1, F3 0 equal to 0, and F2. Figure 85.6. A heavy hook is placed anterior to the neck of malleus, which has been separated from the tympanic membrane and divided from tensor tympani. It is then pulled posteriorly, and the anterior malleolar ligament gives way to allow the malleus to be placed more posteriorly. B. The repositioned malleus now lies directly over the stapes. Total ossicular replacement prosthesis TORP. TORPs bear structural similarity to PORPs, with the range of head designs often shared. However, the strut is longer to reach the stapes footplate, and the medial end of the prosthesis is often flattened to rest on the footplate rather than cupped. As with props, some designs of TORP are shaped specifically to accommodate the malleus handle with a notch or groove, whereas there have been a flat disc leaving both footplate to malleus and footplate to tympanic membrane options open. One of the challenges of this type of reconstruction is the tendency for prosthesis displacement. TURPs can be placed directly on the stapes footplate, although stability may be improved with a cartilage shoe or a specifically designed footplate prosthesis. The footplate shoe acts as an anchoring point for the medial end of the prosthesis, thereby reducing displacement while helping to direct the vector of force through the center of the footplate, improving sound transmission. Malleus absent, stapes present. Austin Cartouche type C. Several retrospective analyses have shown absence of malleus handle to be a major independent prognostic factor, resulting in poorer hearing outcomes following reconstruction. This is partly due to the loss of the amplification produced by the tympanic membrane malleus handle complex and loss of a solid point of fixation for any reconstructed assembly. The simplest surgical option is to proceed with a stapes to tympanic membrane reconstruction as described above for type A defects. An alternative approach is to recreate the malleus handle, either with autologous material or with the prosthesis. Homograft tympanic membrane with attached malleus handles have also been used widely. Neomalleus. Creation of a neomalleus strut can be achieved with incus, cortical bone, or cartilage. Black showed the superior hearing outcomes with a neomalleus assembly technique as compared to columella only approach. He described a neomalleus strut being placed medial to the tympanic membrane graft with the preferred source being a strip of cartilage from the root of helix. Malleus replacement prosthesis. The design and the use of malleus replacement prosthesis is a recent development described by Vincent et al. Patients receiving the malleus replacement prosthesis showed improved hearing results as compared to a foot plate to tympanic membrane TORP. 12.5 decibel airborne gap and 23.3 decibel respectively, and reduced prosthesis displacement. Figure 85.7 TORP with foot plate shoe. A. The foot plate processes is in position on the oval window beneath the facial nerve. B. A typical configuration with the cartilage and perichondrium graft between the processes and tympanic membrane. Malleus and stapes absent. Austin Kurtosh type B. D. This is the most challenging ossicular defect and is likely to lead to the poorest outcomes. It may be managed with a combination of the above techniques and will require reconstruction with autologous tissue, ossicle interposition, or TORP. The reconstruction may be foot plate to tympanic membrane or alternatively a neomalleus or malleus replacement prosthesis may be used to improve stability. Operative considerations, length of prosthesis. Several studies have investigated the effect of tension of reconstruction on sound transmission at the oval window. Lower tension reconstructions with the short processes resulted in better sound transmission than higher tension reconstructions with long processes. The beneficial effect of a more loosely fitted processes on hearing must be balanced against the potential risk of displacement. State reconstructions. As the majority of ossicular chain defects arise as a consequence of chronic suppurative otitis media, tympanic membrane retraction, or Constatoma, the primary goal of the initial operation is generally to achieve a safe dry ear. The decision whether to attempt ossicular chain reconstruction at the first operation or whether to perform a staged reconstruction at a later date depends on several factors. The most important issues to consider are the risk of recurrent or residual disease. Eustachian tube function is a key determinant of outcome following tympanoplasty surgery, and the associated tympanic membrane retraction causes specific problems in ossiculoplasty due to increased risk of processes displacement or extrusion. Similarly, where there is judged to be a significant risk of residual cholesteatoma, performing primary ossiculoplasty can complicate potential revision surgery if the recurrence involves the reconstructed ossicular chain. In years at higher risk of retraction or residual disease, it may be prudent to delay reconstruction until a disease free, aerated middle ear space has been achieved. However, it is often possible to offer primary reconstruction, particularly as improved imaging techniques with diffusion weighted magnetic resonance imaging allows the position of radiological cholesteatoma surveillance without necessitating second look surgery. Audit and research. One of the challenges facing osteoplastic surgeons is being able to predict what outcomes is likely to be achieved with a particular type of reconstruction or prosthesis. While published series may give an indication of the range of outcomes that can be expected, it is essential that the surgeons are aware of their own results when presenting patients for surgery. Individual data collection and self audit may be facilitated by specialized software or internet based data entry. There is a paucity of randomized controlled trials for evaluating ossiculoplasty methods or prostheses. Most results published in the literature are case series from a single surgeon or institution, with comparisons often occurring at the time of transition between an established method and a newer method. Comparing results between studies may be confounded by several uncontrollable variables such as population differences, case complexity, although previously mentioned risk scoring systems may help adjust for this, and perhaps most importantly, surgical technique. It is important to be aware of variations in the way results are reported, as there is no universally accepted measure of a successful outcome. The main considerations following osteoplasty are hearing results and complication rates, which may be prosthesis related, extrusion, displacement, inflammatory reaction, or general graft failure, taste disturbance, etc. Most studies report short observation periods of 1 year. However, it has been established that audiometric results frequently deteriorate over time and complications may present after many years. Key points. While process design and surgical techniques undoubtedly affect results, the status of the middle ear is probably the most significant factor in outcome. Surgical results from ossiculoplasty tend to deteriorate over time. As ossiculoplasty results are variable, surgeons should endeavor to record their own results to enable accurate consent of their patients. Thank you.